Hello, everyone. I'm Leonel August Rodriguez, the VP of Business Development for Access Medical Labs. I'd like to thank everyone for joining us on another Access Live, where we bring you insight from leading medical experts. We do ask that all questions are submitted via the Q&A, as they will be answered at the end of our lecture. Today, I am honored to present to you an individual who has been speaking internationally and contributing to the field of medicine for decades. He is board certified in orthopedic surgery, pain management, anti-aging, and regenerative medicine. He is the founding member of the Institute of Regenerative Medicine and Molecular Orthopedics. Without further ado, Dr. Joseph Purita.
What we're going to talk about tonight is intermittent hypoxia therapy for improved performance and general well-being and longevity. And it seems like that's almost kind of counterintuitive. Wait a minute, hypoxia, longevity, health doesn't seem to jive, but yes, it does. And we're going to get into that. So basically, here's some learning objectives, but the learning objectives are whatever you want to make of it. But anyway, here's kind of a mascot for longevity, the bowhead whale. You know, these whales, there's several whales in the ocean today that were alive when James Monroe was the president. They were alive even before the Declaration of Independence was signed. The question is, what gives them such longevity? Well, they do two things that we know about. They do intermittent hypoxia therapy and intermittent fasting. So that's something that's pretty interesting there. So basically, we know that these two modalities, by and large, can cause, we know for sure about intermittent fasting. We know that that does increase mitochondrial health, et cetera. But interestingly enough, intermittent hypoxia does many of the same things. And here's some more interesting facts about hypoxia. When we develop inside our mother, we're basically at a PO2 of about 16,000 to 19,000 feet. There's some residents in the Hunts Valley. They live at about 8,000 feet, and they have about 15 to 20 years longer longevity than we do. In the Andes, when they've done narcolepsies, basically have not found any evidence of mitochondrial disease after 14,000 feet. So you can see there's a lot of things there. So this is what I call an old, new, or new old disruptive technology. And what's interesting about this is basically, you know, something that we learned from the 1930s in the former Soviet Union. They were the ones that really kind of took this and really ran with it and really started doing things about it and saying, hey, this is going to be good for our athletes, but this is going to be good for general well-being. And we can see here that exercise and altitude training have been the traditional gold standard of intermittent hypoxia. Now, when you started saying this, you say, wait a minute, oh yeah, you know what? Come to think of it, elite athletes, they actually go and train at altitude. Now that starts to make sense. Now the pieces of the puzzle start fitting together a little better about it. Now, hypoxia training methods, basically, this is a good article right here. They can improve endurance and exercise performance. And, you know, nowadays, when we start dealing with pro athletes, college athletes, et cetera, we have to be very, very critical of WADA. We have to be careful about that. We certainly don't want to get these athletes in trouble and have them get suspended or thrown out of their league or something like that. So what we have to realize, though, is there's a big difference between chronic hypoxia and intermittent hypoxia. Now, chronic hypoxia is a hallmark of many degenerative conditions, including cancer, et cetera. Now, basically, a good example of intermittent hypoxia, chronic hypoxia, is sleep apnea. Now, we know that they're similar, but yet they're a lot different. The real critical fact here is what we call the hormesis effect, okay? And we'll get into that shortly. So here's some of the differences between chronic and intermittent hypoxia. You can see, just go down the list, and you guys can look at these slides. We'll make them available to you. So there's no rush to kind of jot things down or take a picture or something or other. But here, again, this is the hormesis effect. So you have normoxia, not really much happens. A little bit of sustained moderate hypoxia, not too much. Now, when it's done intermittently, okay, we start getting some very good things. This is where we get our optimal gain. Then we start getting over to the curve here, sleep apnea, intermittent severe hypoxia, and then sustained hypoxia, and then eventually stroke, death, et cetera. So that's what's really the critical aspect here. So again, the hormetic effect, like most things in medicine, it's so important. That special dose is what gives you the benefits. And that's the same thing with intermittent hypoxia therapy. So basically, low dose stresses will provide future protection to the cells. So we can see here when we have a high dose or a high amount of hypoxia, we get the cells in stress, cell damage, cell death. whereas a low dose will actually cause the cell to make adaptive changes, and lo and behold, repair mechanisms, and you'll have improved protection for future stress and basically a healthier cell and a healthier person. Okay, so here's some interesting things here. Intermittent, and this is an article that I'm just giving you some quotes here from, intermittent hypoxia therapy or training induces telomerase. It basically makes the cells younger. It has all sorts of things in here. It includes, for those of you that know about mesenchymal cells and things like that, pluripotent markers, some very interesting things. It seems to kind of quell some of the cell senescence and things like that, whereas intermittent hypoxia and sleep apnea goes the exact opposite. It causes telomere shortening and all sorts of bad things. So we can see here interval hypoxia, training, preconditioning, a number of different transcription factors are basically stimulated by this. So we can see what happens there, but we'll get into this in a little better stead here. So basically, hypoxia is one of the most powerful inducers of gene expression, metabolic changes, and regenerative processes, including angiogenesis, stimulation of stem cell proliferation, migration, and differentiation, and the fluctuations in the free oxygen concentration rather than the absolute levels of oxygen can be interpreted at the cellular level as a lack of oxygen. So, we can basically vary the oxygen content from 9% oxygen to 40%. And that is what really creates the magic, that variation in oxygen concentration. So basically, we can see here that oxygen homeostasis is basically a balancing act. You have oxygen demand, and remember now, oxygen does cause free radical formation, and you have your oxygen supply. And what we're dealing with here is something called hypoxia-inducible factors, and we can see it right here. Now, these are actually transcription factors that are stimulated by low oxygen levels. Remember, a transcription factor basically works its way into the nucleus. And when it gets into the nucleus, it then starts helping the genes transcribe. It gives them messages to make certain compounds. And you can see there's basically three major subgroups of the hypoxia-inducible factors, alpha, beta, and gamma, more or less. So here we are here. So under normoxia conditions, we have the hypoxia-inducible factors here. It kind of mixes with the oxygen, and eventually it just gets the degradation. It just goes and forms some peptides. Doesn't really do much of anything. It's hanging out in the cytoplasm. Now, when we have hypoxia, guess what? That hypoxia-inducible factor basically gets released from its stranglehold, so to speak, and it makes its way into the nucleus, and then it goes to the target genes, and it makes hypoxia response elements. It makes a whole host of various different things. And this is where the magic occurs, so to speak. And this is just another picture showing you the same thing. Hypoxia, we get this, and it goes in here. So basically, we know that hypoxia will stimulate hypoxia-inducible factors. It goes into the nucleus, and it starts performing a host of different things. So again, it's held in the cytoplasm, and when it gets the signal of a low oxygen, it gets released into the nucleus. And you can see the various things here that hypoxia-inducible factors can do. Erythropoiesis, oxygen sensing, cell cycle control, mitochondrial function, very important, obviously, angiogenesis, apoptosis, etc. So the hypoxia-inducible factors control oxygen delivery by regulating angiogenesis, vascular remodeling, oxygen utilization. Now, they also can basically be induced through changes in the the messenger RNA. Also, again, they do the transcriptions of genes encoding various transporters. They do work on mitochondrial proteins that can decrease oxygen utilization, make them function more readily. And they can also help with glycolytic metabolism. So they can make, instead of 4 ATP, they make 2 ATP, but they also stimulate something called hemoxygenase 1, which we'll get into in a little bit. So here we can see here some of the genes that this will target. Erythropoietin, vascular endothelial growth factor, inducible nitric oxide synthase, glycolytic enzymes. So it goes on, and all of them are basically helping improve oxygen transport. So what seems contradictory is hypoxia will actually improve your oxygen transport. Now, erythropoietin is a very important compound. It's been reported as an active signaling molecule, and it's a transcription factor. It does many different things. You'll remember from many years ago, Lance Armstrong basically got in trouble because he was using erythropoietin and doing blood doping. But if you do intermittent hypoxia training, there's going to be no problem there. That's just like you're training at altitude. But you can see here, erythropoietin doesn't just make red blood cells. It has a lot of different effects. It can help bone remodeling. It can help in the fat going from white fat to brown fat, helps with myoblast. It helps with heart endothelial tissue, endothelial nitric oxide synthase, which is an enzyme we really want for health, so to speak. So basically, it can release VEGF, vascular endothelial growth factor. Now, VEGF is something that can really help you make various blood vessels and things like that. And it makes angiogenesis, the remodeling of collateral blood vessels to handle increased flow. It's a signaling protein, and it can stimulate angiogenesis, vasculogenesis, and there's a big difference between the two, which I'll get to, I believe, on the next slide. It also stimulates SDF1, which is stem cell-derived factor 1, which allows stem cells to home to the area. So much more than just making blood cells. It does so many different things. Now, here's a concept I want everyone to really get a handle on, the difference between angiogenesis and vasculogenesis. Angiogenesis, you're basically building on vessels that are already there. You can see we have a vessel, we're making a little better vessel. Whereas vasculogenesis, basically we're not having any vascularity to begin with, and we're making new vessels and things like that. So there's a big difference between that. Typically, angiogenesis can be stimulated by VEGF, so like a PRP, for instance, whereas SDF1 is basically from stem cells. So that's why a lot of times when you have a very avascular area, you'll need to use some stem cells in addition to just PRP alone. Now, hemoxygenase 1 is another compound that's stimulated by hypoxia-inducible factors. And you can see here that it's very important in reducing inflammation. Oh, let me go back. Sorry about that. Now, what it does is it can produce biliverdin, which is a very strong antioxidant, which goes on to bilirubin. It can take iron and make it into ferritin. But very interestingly, it also helps produce carbon monoxide. Now, carbon monoxide is an extremely important signaling gaseous molecule in the body. You cannot survive without carbon monoxide. End of discussion. But again, it's a very toxic compound. We have to remember the hormesis effect. Very low dose is very important for us. The higher dose is deadly, and we all know that. So remember, that is a very important aspect of HIP and things like, HIF and things like that. Now, another thing for hypoxia-inducible factors, it upregulates the mesenchymal cells, and it also upregulates the macrophages. Now, for those of you that may not know, there's two types of macrophages. There's a macrophage 1, which is very good in an infection, but not so good if you're trying to regenerate tissue. And there's a macrophage 2, which is something that actually, believe it or not, can help regenerate tissue. Now, macrophage 1s are good when you have an infection, but not good when you're trying to regenerate tissue. So hypoxia-inducible factors basically polarizes these things and makes them go more towards an M2 macrophage. So it's a very important aspect in regenerative medicine. If you're getting more M2 macrophages, you're going to really have a much better chance of regenerating tissue and getting that patient better. And you can see here also hypoxia-inducible factors helps produce P53. Now, P53 is called the tumor suppressor gene. Many tumors arise from a defect in this gene. The problem that we have many times is our P53 becomes damaged by DNA damage, et cetera, and it can lead to cancers. Now, for instance, an elephant, which has multiple copies of the P53 gene, almost never gets a cancer. So we think that hypoxia-inducible factors may help produce more P53 and may help it actually become corrected if it has DNA damage. So nitric oxide, you know, there's not much need to be said about that. It's such an important, again, gaseous signaling molecule. Very important for many different things. There's 3 different enzymes that produce it: inducible, endothelial, and nitric oxide synthase. Now, many different roles in stem cells. Oh, sorry about that. My finger's too active. We know that basically it can help preserve stem cell potency, okay? It also can keep stem cells from differentiating, and it preserves their stemness. This is what allows your stem cells to kind of, you know, they're very quiescent if they're in hypoxic conditions. Your bone marrow, PO2 is in the 80s. When that bone marrow stem cell gets a higher oxygen, it starts to differentiate. It can form the blood vessels, and also it's very important to the survival of chondrocytes, okay? Another important aspect, and this is what we use a lot in our office, something called a very small embryonic-like stem cell. It's found in each and every one of us. I call it an emergency stem cell supply. It typically only gets instituted when you're in some stress. Now, we know that there's certain supplements we can give the body to stimulate these cells to go into the circulation, but they're still quiescent. So in order for us to activate them, we have to take them out, process them, and put them at 4 degrees centigrade and hypoxic conditions overnight. But it's a very potent cell, and it's, pretty much the way I say it's like an embryonic cell, but it's your own. Now, there's some clinical aspects that we need to be aware of also with hypoxia. It can help with body weight and basically metabolism, cardiovascular response, and respiratory responses. Now, a lot of things on this one slide. I'll try and kind of go over them little by little because I know we have time limitations. So hypoxia can have an influence on your weight. It can actually help with appetite suppression. Those of you that travel to the mountains, maybe going skiing or something, you know how sometimes you say, oh, I just don't feel hungry. You get the altitude anoxia. Okay, now it can increase leptin levels. It basically can increase energy expenditures, and it can have a metabolic effect. Now, some of the other effects, it can increase body weight loss, suppresses appetite, decreases cholesterol, decreases blood glucose, improves insulin sensitivity, and we go on and on and on. So obesity itself is a big worldwide problem. Now, we know that some of these semaglutides and things we're using are really working well, but all of a sudden we're going to start finding that when you start getting these patients off the semaglutides, there's going to be a rebound. These people are going to get hungry. They're not going to be able to control their appetite, and they're going to start gaining weight. Hypoxia may be a way of dealing with that because it can affect the metabolism. It can help with insulin sensitivity, and it can also help with leptin sensitivity because the leptin is what's going to make you want to eat more food, and you become unsensitive. You have leptin resistance, and it just is a vicious cycle that goes on and on and on. And these couple of slides are basically showing you that. So hypoxia-inducible factors have also been shown to regulate glucose sensing in the central nervous system, which is of key importance. That's really what probably is so important. The hypothalamic gland, how it senses glucose is called hypothalamic glucose sensing. It's a very important thing compared to long-term regulation. It's very important. It can be quick, and it can be very timely. And again, I'm talking about leptin here. Leptin is going to be something we're going to have to start dealing with once we get these people off the semaglutides, for those of you that are using it. And again, it causes a lack of sensitivity to leptin, but the hypoxia-inducible factors will basically bring that sensitivity back. Now, another thing, hold on one sec, is that hypoxia-inducible factors will, via regular leptin, et cetera, does something called suppressor of cytokine signaling. Remember, cytokines are basically how a lot of the immune cells communicate with each other. And what hypoxia-inducible factors can do is it can kind of down-regulate those things. And for instance, you have NF-kappa beta. Well, that basically is a cytokine when all said and done, and it can be diminished because you have all the different cytokines here. And guess what? We can suppress their signaling targets by hypoxia-inducible factors. And again, this just is another slide, and you can go over this at your leisure, showing how leptin really gets involved here. Now, other major metabolic pathways stimulated by intermittent hypoxia, well, you have, various AMPK, a very important pathway. We know that's a very important nutrient sensing pathway, helps with mitochondrial regeneration, et cetera. Now we have the PGC1 alpha, basically mitochondrial biogenesis. And basically, it seems to also help with NAD production, et cetera. Now, when we talk about intermittent hypoxia, there's two types that we need to be aware of. There's systemic, which kind of I've been talking about all along, but there's another one we use in sports. It's called local hypoxia, okay? And that can be basically when you're doing it only on an extremity, et cetera. And this is what we call blood flow restriction, where we use some very specialized tourniquets. They can sense what the blood pressure is, and they'll allow a certain portion of blood to pass through. But they won't completely restrict the flow, but they'll just allow a certain to go through. Now, what happens is when you do this, It can dramatically increase various cytokines, including IGF-1, myostatin blockers, which is a holy grail of bodybuilders. So we can see here. So here's the bottom line for blood flow restriction. A low intensity exercise will mimic and surpass the benefits of a very high intensity exercise without the patient really going crazy and exercising, getting sore muscles, et cetera. It can also block other pathways and important pathways at that. And then it can also stimulate them like AMPK and blocking of mTOR. Brain-derived growth factor or neurogenic factor is another one that it can help build. And again, these are some of the secrets, but you can see here some of the benefits that we have. So here's high intensity. Well, we can get some muscle damage, but with the blood flow restriction, we really don't get muscle damage. We have lactate production, yes, similar in the two, but look at some of this growth hormone. We get 1.7 times greater growth hormone secretion than high intensity exercises. And IGF-1, significant increase. This is just an increase in high intensity. And mTOR, significant increase. Myostatin, downregulation, time to adapt. Well, you do high intensity, it's going to take you 12 weeks to really start seeing good benefits. Low intensity with blood flow restriction, 2 weeks. So now you start seeing how this may be good for your athletic patients, et cetera. And again, whatever happens during blood flow restriction, again, we get venous inflow is diminished, venous and arterial inflow. And that's what happens. Then when you release that tourniquet, you get increased arterial flow and increased venous flow. And you'll basically really start getting some very good things happening. And this is just a little slide with the different myokines. You know, remember the myokines are like cytokines, except they're secreted by the muscle. And you have a whole host of different myokines in the body. And again, you can have brain neurogenic derived factor, very important for your brain. That's why they always used to say a sound body means a sound mind. And that's where we're seeing that because we need the muscles to help our brain survive and do well. Okay. So systemic hypoxia, on the other hand, is delivered by a specially designed machine. And the machine we use happens to be between 9% and 40% oxygen. The sessions can be anywhere from 10 to 30 to 90 minutes. Typical session for us is about 30 minutes. Okay. And here's some conditions that can really be helped by intermittent hypoxia therapy. Asthma and bronchitis, you'd think, oh, that's not a good thing. Yeah, it actually helps. Same thing with heart disease and lung diseases. Again, you would think that hypoxia would be contraindicated, but it's not. Hypertension, increased mitochondrial number and inefficiency, aerobic and anaerobic performance. These are the things that can really be found with this. Now, contraindications, well, chronic COPD, some chronic diseases or terminal illness. Cancer, you know, that's kind of iffy. You know, we don't want to put a target on ourselves, but most likely it probably wouldn't do much good. I'm not sure if it's going to do much harm either, though. Now, epilepsy, pacemakers, heart arrhythmias, I'm not really sure if that's a big problem or not. This is what machine we happen to use right now looks like, but we're looking into getting another machine and maybe even helping to distribute it. We'll see. So you can see here, you basically put your finger in a sensor, you put a mask on, you breathe in the air, and then it just, you know, starts doing its magic. And then it starts varying the amount of O2 that you're getting from 9%, which is half of what we get at room air, essentially, to about 40%. And again, we'll do a few minutes of hypoxia alternated with normoxia or hyperoxia. We prefer hyperoxia, and I'm going to get into that shortly. A full course is about 3 to 4 weeks. You do it maybe 3 to 4 times a week. And you can see here. Now, what you really are looking for is something called the hypoxic treatment interval. Basically, you want to really get your PO2 less than 90. That's really where you start getting things that'll happen. And that's called the hypoxia training index. I've gotten my PO2 down to about 78, and I still feel fine, but I've been doing it for a little while. But you still have to monitor your patients somewhat. How is it helpful? Well, basically, you can get compensation. And again, you really want to look at hypoxia levels that drop below 90 degrees, 90%. Anything above a PO2 of 90 or above is really not going to help too much. And this is due mainly to the oxygen and hemoglobin dissociation curve. 90% or higher concentration will produce little effect. Okay, so basically, that's what I said here. Now, we do basically 8 4-minute bouts of intermittent hypoxia. You can really get a lot of increase, and we found that can significantly increase erythropoietin levels in healthy individuals. Just 8 4-minute bouts of intermittent hypoxia. So you can see it can work pretty quickly, like I say. Again, this is just a little bit of the oxidation dissociation curve. You know, when you're over here on the right side, basically you have less oxygen affinity and more oxygen unloading, but we're going basically this way. So we have higher oxygen affinity and less oxygen unloading. Now, here's something that I really like, and this may be a shortcut for many of you guys. You may be familiar with the study in Israel where they said, well, you know what? We're using hyperbaric oxygen, but we're doing it basically having the patient breathing in the 100% oxygen and then taking an air break of 5 or 10 minutes. And they said, well, you know what's happening? We're actually getting these people to have their telomeres of their immune system get longer over a period of time. And they said, really what it is, yeah, we think the hyperbaric helps, but we really think it's that change in oxygen concentration. Well, what are we doing with the intermittent hypoxia machine? We're doing the same exact thing. We're basically varying that oxygen concentration. It's going to stimulate your telomeres. So basically, that's what we think we're doing here. We're getting fluctuations in free oxygen concentration rather than the absolute level of the oxygen that can be interpreted at the cellular level as a lack of oxygen. So that's what's happening. We're fooling the body. Now, if you're using a chamber where it's 100% pure oxygen that the patient's breathing in, you're gonna not be able to do this unless you do some kind of air break with them, you know, put a mask on with room air, I guess. So this is called the hypoxic paradox. And basically, again, this is what we're doing, faster recovery. So we use that instead of normoxia. We don't really use normoxia for this. You could, but I don't think you're going to get the benefits that you want. So basically, again, another reason why we do it, it's a natural trigger of mitogenesis and mitochondrial metabolic changes, vascular endothelial growth factors, and all other molecular cascades and stem cell proliferation. Again, another article showing the same thing, effects of intermittent hypoxia, hyperoxia in performance and health-related outcomes. Same thing. And another article basically talking about telomere length. And with that, I'm going to be open for questions.
On behalf of Access Medical Labs, I would like to thank you for an incredibly informative lecture on IH therapy. If before the questions, if you could kindly tell the audience where they can reach you for peer consultations.
And now we'll go to the first slide. It has all the information you need on it.
Excellent.
So there we are.
Excellent. All right. Thank you for that, sir. So first question from the audience is, and I believe you may have answered this on slide 54. How soon after the IH therapy should patients start to see results? And what would be the first sign that the therapy is working on that specific patient?
Well, you know, again, it depends on the patient himself, but it depends on what we're doing now. If we're talking about systemic versus blood flow restriction, you're going to see within a week or less. The systemic may take a little longer, but it's interesting because, you know, a lot of people do this before they go out west to go skiing. And they said, oh my God, when I got out there, I could do the stairs. I could do this and that. I wasn't out of breath for 2 days. So again, it depends, but you may at sea level, you're not going to necessarily see as much of a change rapidly. It's going to do a lot of changes of your pathways, but that's it. But blood flow restriction, you'll see a change within a week or so. You're going to see that patient's getting stronger and feeling better.
Excellent. Excellent. Next question is, what pre-existing conditions, if any, should be addressed with a patient prior to undergoing any type of IH therapy?
Again, you know, chronic COPD, things like that, terminal conditions, pregnancy. I mean, you know, you just you have to kind of wing it a little bit and think about the patient. But, you know, typically when we do this, we have a nurse that watches the patient initially. And then we see how they do for 1 or 2 sessions and if they're having no problems. And usually if they don't have a problem by the first 1 or 2 sessions, then we just, okay, fine. And we just set that up and that's it. So there's really not too much that I'm really worried about. I can't say, oh, I'm worried about this, worried about that. I mean, if you have somebody who's gasping for air to begin with, you don't want to start getting their PO2 down to, you know, in their low 80s or 70 something.
Absolutely. Okay. And I believe you also may have answered this one as well. How does IH therapy directly prevent weight loss or weight gain after weight loss combined with leptin resistance?
Well, that's just it. The intermittent hypoxia factors, hypoxia-inducible factors, I should say, will basically help you get rid of leptin resistance, just like insulin resistance. You know, you make insulin, but your body's not using it properly. Same thing with leptin. It'll help you get leptin sensitivity back.
Excellent. And Dr. Purita, my last question. Aside from the oxygen monitoring devices that you showed, any other type of maybe blood work or assessment or tests that you suggest to ensure that the patient is reacting positively to a IH therapy?
Well, I mean, it's interesting. I'm not sure. I mean, you could probably look at some inflammatory markers and see if they're going down because you're going to reduce inflammation. They're going to basically, the mitochondria are going to work better, so that should help also. Other than that, I mean, well, another one obviously would be their blood count, see how their blood cell count is. I mean, it should start going up because they're getting erythropoietin.
Excellent. Okay, so like a CBC, CRP, possibly.
Yeah, simple, easy labs, nothing really exotic, I mean, to start with, and you go from there.
Excellent. Wonderful. All right, Dr. Purita, once again, on behalf of Access, we'd love to thank you for joining us on Access Live. To our audience, thank you for tuning in to another Access Live, where we bring you insight from leading medical experts. Don't forget to like and subscribe and stay healthy. Till next time.
Thank you so much. It's been my pleasure, everyone. Have a good evening. Bye now.
Thank you, sir. Bye-bye.